Welcome, dear viewers, to today's session. And we are happy to have you with us today. I hope you enjoy this session. The topic is tracheostomy beyond the procedures. So obviously, we will not be discussing the procedure as such, but the physiology, the complications, the indications, and the other things associated with tracheostomy. Everybody knows how important tracheostomy is for the patient in the ICU. And the speaker today is Dr. Velmurugan Selvam. So Dr. Velmurugan has done his DM in critical care medicine from the prestigious All India Institute of Medical Sciences, and he is now Associate Professor, Department of Critical Care Medicine at the Sri Ramchandra Institute of Higher Education and Learning at Chennai, India. So with that, I hand it over to you, Dr. Velmurugan, to take us through the next 45 minutes or so.
Thank you, sir. Thanks for the introduction. Good evening, everyone. First of all, I would like to thank Dr. Tapeshwar and the Forum Young India Intensivist Forum for giving me this wonderful opportunity and for inviting me. So the topic given to me is tracheostomy beyond the procedures. Sir has clearly told me not to talk about the procedure in detail. So what I will be talking about is, I'll be discussing about the advantages and the timing of tracheostomy in critically ill patients, the types of tracheostomy tubes, their advantages and disadvantages, how to select appropriate tracheostomy tube, not only the size, but also the appropriate type of tracheostomy tube, how to make the patient with tracheostomy tube speak, that is communication with patients with tracheostomy tube, and decannulation, how and when to proceed with decannulation, and complication. Because of lack of time, I won't be discussing in detail regarding the complications of tracheostomy in detail. I'll be briefly talking about tracheostomy fistula, the major catastrophic complication that can happen with any patients with tracheostomy. First, what are all the indications for tracheostomy in a critically ill patients? There are mainly three indications for tracheostomy in a critically ill patients. One is upper airway obstruction. It can be due to angioedema, it can be due to anaphylaxis, severe epiglottitis, retropharyngeal abscess, etc. The other two indications are prolonged mechanical ventilation to facilitate weaning from positive pressure ventilation. The other is neuromuscular disease like Guillain-Barré syndrome, severe stroke, mainly to facilitate secretion clearance. There is some difference between indication for tracheostomy in these three conditions actually. In case of upper airway obstruction, there is no ambiguity. The timing of tracheostomy is very clear. It is immediate and has to be done as soon as possible. And also decannulation, once the upper airway obstruction is completely relieved. So the patient, once you have done the tracheostomy, once you have, for example, in a case of retropharyngeal abscess, you have drained the abscess, you do an FOL, the abscess is completely drained, you can proceed with decannulation safely without any major complications. Whereas in other two indications, that is prolonged mechanical ventilation and neuromuscular disease, there is no clear certainty regarding the timing of tracheostomy, whether it is early tracheostomy or delayed tracheostomy, and there is no clear indications when to, there is no clear guidelines when to decannulate and when to decannulate the patient from tracheostomy. So it's in upper airway obstruction, the timing is clear regarding indication, timing of tracheostomy and decannulation. In the other cases, the timing and decannulation is still uncertain. So what is the advantage of tracheostomy, or when should we, what is the advantage of early tracheostomy? So several studies has been conducted in critically ill patients that have compared early tracheostomy versus delayed tracheostomy in critically ill patients. All these studies have consistently shown that early tracheostomy is associated with decreased duration of mechanical ventilation, decreases ICU stay, decreases the need for sedation, and improved comfort actually. Whereas in terms of hospital and ICU mortality, in terms of ventilator-associated pneumonia incidence, there is some uncertainty. However, the recent meta-analysis of randomized control trial that was published in Critical Care Medicine in 2021 has shown that early tracheostomy, that is tracheostomy between 7 to 10 days, is associated with improvement in short-term outcome, but it was not statistically significant, and also decreased the incidence of VAP, that was also not significant. Overall, there is some clinical advantage of early tracheostomy over delayed tracheostomy in terms of duration of mechanical ventilation, duration of ICU stay, decreases the need for sedation. However, in terms of mortality and VAP incidence, though there was no clear benefit, there was trend towards advantage towards the early tracheostomy. However, in patients in the early tracheostomy group, more patients underwent or more patients are being tracheostomized in the early tracheostomy group compared to the delayed tracheostomy group. And there is more procedure-related complication in the early tracheostomy group actually. So when should you plan tracheostomy in your patients actually? So there is no clear evidence, there is no clear certainty. The timing of tracheostomy must be decided on case-to basis actually. When the patient is predicted to have prolonged mechanical ventilation of more than 14 days, you can proceed with early tracheostomy between 7 to 10 days. However, as a clinicians, we are very poor at predicting whether the patient will be requiring prolonged mechanical ventilation or not actually. So there were several scoring system has been developed, especially recently there was a trial, set point trial that was published in neurotrauma patients where they have used the set score to predict duration of mechanical ventilation. However, none of the scores are clearly validated or very poor at predicting whether the patient will require prolonged mechanical ventilation or not. So in selected group of patients, especially in patients with neurotrauma, Guillain-Barré syndrome, major stroke may benefit from early tracheostomy between 7 to 10 days. However, if the patient is clinically improving, the secretion is getting thin, the neuromuscular power is getting better, if the hypoxia is improving, so we can wait up to 10 days. So clearly there is no certainty regarding the timing of tracheostomy in ICU patient. You have to decide on case-to-base basis. So in neurotrauma, neuro injury patients, traumatic brain injury patient, you can proceed with early tracheostomy, whereas in other critically ill patients, can wait up to 7 to 10 days actually. So coming to the types of tracheostomy tubes, tracheostomy tube based on the material from which the tracheostomy tubes are made. The tracheostomy tubes are broadly classified into three types actually. First is metallic tube, the other is PVC tubes, which includes the plastic tube, which includes PVC and silicone tube, and the third is reinforced tube actually. So metallic tube, also called Jackson tube, it is no more used in any patients actually. The advantage of metallic tube is actually made of stainless steel and silver actually. So it will inhibit bacterial growth, it will inhibit biofilm formation, so it will decrease the risk of infection and ventilator-associated pneumonia. Main disadvantages is very rigid, it is associated with traumatic complication while insertion and while removal. And you don't have a cuff, so it can be used for patients with positive pressure ventilation. You don't have a 15 millimeter standard connector, so it cannot be connected to a patient's connected to a ventilator actually. So it can be used only in patients who require long-term tracheostomy, mainly for secretion clearance actually. So metallic tubes are very rarely used in critically ill patients. The most commonly used tubes are plastic tube, that is PVC tube, and the silicone tube actually. PVC, the advantage is it usually softens at body temperature. When you place the tube, it conforms to the anatomy of the trachea, centering the tube in the trachea. Whereas the silicone tube usually don't softens at body temperature. However, it has a special characteristic that will inhibit biofilm formation so that it will further decrease the risk of infection and pneumonia. So you can use any tube, either silicone tube or the PVC tube. The most commonly used tube in my place is PVC tubes. We use Portex tube most commonly in our ICU. The other commonly used tube is reinforced tube. Reinforced tubes are very rarely used, only in those patients who request a special types of tube, that is, patient who require extra long tube. This reinforced tubes are known. I will talk about this tube in detail in the coming slides. When coming to sizing of the tracheostomy, how the tracheostomy tubes are sized actually. There are two ways by which the tracheostomy tubes are sized. One is Jackson sizing, the other is ISO sizing. The Jackson sizing is basically based on length and taper of the outer diameter. So all the metal tracheostomy tube and the Shiley's regular tube uses Jackson sizing, whereas other manufacturers, the Portex and Biona tubes, uses ISO sizing. ISO is basically International Standardization of Organization. All the other manufacturer uses ISO sizing, and the Shiley's extra length tube uses ISO sizing. Mainly the metal tube and the Shiley's regular tube uses Jackson sizing, and the ISO sizing is used for all the other manufacturers. You can see two pictures. This is ISO. This is actually the Jackson sizing, and this is ISO sizing. The Jackson sizing based on the length and taper of the outer diameter, whereas the ISO sizing is based on the internal diameter of the outer cannula. For single lumen tube, it is internal diameter of the outer cannula is taken as a size, whereas for tubes that requires inner cannula to connect to the ventilator, they like Portex Unipac tube and Trocar Plus tube, so it is taken as inner diameter of the inner cannula. The importance here is, while selecting the tracheostomy tube, don't see only the size of the tracheostomy tube, because, for example, this is Shiley's type sewing. So, for example, the same Shiley's 8 size and this is Sportex tube actually, can have a different internal diameter and outer diameter. So while selecting a tracheostomy tube, don't only look at the size of the tube, always look at internal diameter and outer diameter, that is external diameter of the tube, because the tracheostomy tube with same size can have different internal diameter and external diameter. What is the importance of external diameter or outer diameter is, the outer diameter normally in the normal outer diameter of the tracheostomy tube should be 2/3 to 3/4 of the tracheal diameter. It should not be more than that, it should not be less than that. If it is more than that, that is if the outer diameter is more, so there will be less space between the tracheostomy tube and the trachea. So in case if you are trying for vocalization or communication, or if you are trying for weaning, there will be decreased space between the tracheostomy tube and the trachea. So it will prevent the air to go into the upper airway. So it will prevent vocalization, and it will prevent communication, and it will prevent the weaning from the mechanical ventilation. So ideally, you should select the tracheostomy tube that has 2/3 to 3/4 of diameter of the trachea of the patient. Ideal recommended internal diameter of the tracheostomy tube is normally 6 to 7 millimeter for female and 7 to 8 millimeter for male. What happens if you select a very smaller size internal diameter is, if you select a smaller internal diameter, the problem will be the internal diameter, the tracheostomy tube can get blocked frequently by the secretions. And if as internal diameter decreases, it will increase the resistance to the glass flow that will impair weaning from mechanical ventilation. Also, if you select a tracheostomy tube with a very small outer diameter, what happens is if you select a small outer diameter, you have to inflate a cuff to very high pressure actually. So it will increase the risk of tracheal mucosal necrosis. So select a tracheostomy tube with appropriate outer diameter, that is 2/3 to 3/4 of the tracheal diameter, and select a tracheostomy tube with appropriate internal diameter, that is 7 to 8 millimeter for male and female actually. So while selecting the tracheostomy tube, don't only look at the size of the tracheostomy tube, always look at internal diameter and outer diameter, because different tracheostomy tube of same size can have different internal and external diameter. Then coming to extra length tracheostomy tube. So to understand this better, you need to understand what is the length of the tracheostomy tube, what is proximal length and distal length. So this is basically each tracheostomy tube has three lengths. One is proximal length, the other is radial length, and the other is distal length actually. So the proximal length is from the flange to the upper curve, and the radial length is from upper curve to the curve down. And the distal length is from curve down to the tip of the tracheostomy tube actually. So this length, that is the proximal length, and the radial length is called the stomal length actually. When you place the tracheostomy tube, this part of the tube lies within the stoma, that is from the skin to the anterior wall of the trachea. So this part of the tube, that is down to the tip of the tracheostomy tube, lies within the trachea. This is called the intratracheal length actually. So what happens is, if you select a smaller size tracheostomy tube, or a patient with obese patient, or a patient with a thick neck, pad of fat in the neck, so this length will increase actually. So when you put a smaller size tube, majority of the tube has to pass to the stoma, that is skin and subcutaneous tissue. Only the small part of the tube will lie within the trachea. So the disadvantage is, when you use smaller size tube for a big patient, then if you do a bronchoscopy and see the tip of the tracheostomy tube can hit the posterior tracheal wall, can get blocked very frequently, can lead to ventilation issues. And also, since only smaller part of the tracheostomy tube lies within the trachea, when the patient coughs aggressively or the patient moves aggressively, the tracheostomy tube can get accidentally removed very frequently. So while you selecting the tracheostomy tube, don't only see the size of the tracheostomy tube, also see the length of the tracheostomy tube. So there are special tracheostomy tubes that are available, that is tracheostomy tube with extra length tubes. Extra length tubes can be extra proximal length, that is extra stomal length, and extra length can be distal extra length tube, that is called extra tracheal length tube actually. So for a obese patient with a thick pad of fat, you select a tube with an extra proximal length, so that larger part of the tube, if you give extra proximal length, so that you will have adequate length of the intratracheal length within the trachea, that will prevent tube obstruction and also prevent accidental removal of the tube. And patient with the tracheomalacia or tracheal stenosis use a tracheostomy tube with a longer distal length, so that it can easily bypass the obstruction, so that there will not be any issues during ventilation. So whenever you are selecting the tracheostomy tube, don't only look at the outer and internal diameter, also look at the length of the tube. For a morbidly obese patient, try to use a longer length tube, that is extra proximal length tube. If you don't have this extra proximal length tube, you can use the adjustable flange tube so that the flange can be adjusted accordingly to the desired length actually. Then single and double lumen tubes. So some tracheostomy tube have an additional inner cannula. The tubes with inner cannula are called double lumen tube actually. The advantage of double lumen tube is the inner cannula can be removed whenever there is an obstruction of the tracheostomy tube. The inner cannula can be removed and washed and can be replaced. So this can be done without removing the tracheostomy tube. So whenever there is an obstruction, you don't need to remove the tracheostomy tube. We can remove the inner cannula, wash the inner cannula, and replace it safely without any major complication. What is the problem with inner cannula is if you use an inner cannula, the internal diameter goes down significantly. When the inner diameter goes down, then that will increase the resistance. So it may leads to weaning issues actually. So in case patient have any major weaning issue, don't have any other option, you can try to remove the inner cannula and try weaving trial frequently. Then fenestrated tubes actually. So tracheostomy tube can be fenestrated and non-fenestrated. What is fenestration? Basically, fenestration are basically pores or fenestration in the posterior wall of the outer cannula actually. What is the purpose of fenestrated tube is mainly for communication and weaning actually. So if you have a fenestration, during exhalation, the exhalation can go into the upper airway that will facilitate communication and weaning actually. What is the problem with fenestrated tube is if you don't select appropriate tracheostomy, if you select a smaller size fenestrated tube, sometimes the fenestration may lie within the skin and subcutaneous tissue. So during positive pressure ventilation, it can lead to subcutaneous emphysema. So when to use? Whenever you are trying to wean and when you are trying to make the patient speak, you use a fenestrated tube. Don't use the fenestrated tube during the acute phase when you are doing tracheostomy. Immediately don't use a fenestrated tube. Try to use a fenestrated tube in the weaning phase or when you are making the patient speak, you can use the fenestrated tube. Don't use it in the acute phase. Then subglottic suction tube actually. So it's similar to endotracheal tube with subglottic suction. These are specialized tube. The most important risk factor for development of ventilator-associated pneumonia is oropharyngeal colonization and microaspiration of the oropharyngeal secretion. These tubes are mainly developed to prevent microaspiration of the oropharyngeal secretion. Apart from the cuff inflation port, there is an additional port that will opens just above the cuff actually. So whenever there is microaspiration of the oropharyngeal secretion, you can continuously aspirate the secretion through a syringe, or you can connect this tube to a continuous low pressure, that is 10 to 20 centimeter of water. This continuous aspiration of oropharyngeal secretion has been shown to decrease the incidence of ventilator-associated pneumonia. Although there is no clear benefit of subglottic suction tube over the normal tube, if you work in ICU where the ventilator-associated pneumonia is very high, despite following the standard infection precaution, you can use tracheostomy tube with the subglottic suction actually. Then tracheostomy tubes are cuff, and there are uncuffed tracheostomy tubes are also available. Among the cuffed tracheostomy tubes, there are different types of cuff that are available. One is high volume, low pressure cuff. That is the commonly used cuff in most of our tracheostomy tube. Another is low volume and high pressure cuff. And the other is self-inflating cuff actually. The advantage of high volume, low pressure cuff is when you inflate the cuff, it will exert uniform pressure on the tracheal wall. So the risk of tracheal wall necrosis or the risk of impairment of tracheal mucosal flow is very less actually. So we tend to use high volume, low pressure for our patient. Then the silicon tube uses high pressure, low volume cuff actually. The advantage is when you deflate the cuff hugs closely to the shaft of the tube. So when there will be, here you can see, even after complete deflation, some amount of the cuff will protrude outside the shaft actually. Once you deflate this tube, the cuff completely hugs the shaft of the tube actually. So there is more space between the tracheal wall and the tracheostomy tubes that will tend to improve communication and will improve weaning from the tracheostomy tube actually. The self-inflating bigona foam-filled cuff is mainly used. Exactly when you place the tube, when we expose the pilot balloon to the atmosphere, the cuff will inflate spontaneously because of the smooth and soft nature. It will exert uniform pressure on the tracheal wall. It will it will not exert over pressure on the tracheal wall. It will achieve adequate seal with a lower pressure actually. So this is not used very frequently. The most commonly used tracheostomy tubes have a low pressure, high volume cuff. The silicone tube can also be used. However, whenever you are using silicone tube, make sure you monitor the cuff pressure very frequently so that it won't impair the tracheal perfusion pressure. Then summary of the tracheostomy tubes. Depending upon the made, it is metal tube, it can be PVC tube, or it can be reinforced tube. Sizing, there are two types of sizing. One is Jackson sizing for metallic tube and the Shiley's regular tube, and ISO sizing for the other manufacturer, and the Shiley's extra length tube uses ISO sizing. The Shiley's extra length tube, that is stomal extra length, that is proximal extra length tube, is used for patients, morbidly obese patient, and for patients with the thick pad of fat in the neck. And the tracheal, the distal extra length tube is used for patients with tracheal stenosis or tracheal malacia. In subglottic suction tube to prevent microaspiration. If you have very high VANP incidence, despite standard infection precautions, you can use tracheostomy tube with subglottic suction. Fenestrator tube, mainly for weaning and communication. Cuffed tube, there are different types of cuff, low pressure, high volume, high pressure, low volume, and the self-inflating cuff. The most commonly used cuff is low pressure and high volume cuff. So make sure whatever cuff you use, at least check the cuff pressure at least once or twice a day so that the cuff pressure don't exceed 20 to 25 centimeter of water. That is a normal perfusion pressure of the tracheal mucosa. If the cuff pressure is very high, it will increase the risk of tracheal mucosal necrosis. And also the risk of subglottic stenosis is very high. So at least monitor once or twice a day by using a cuff pressure manometer. Then communication. One of the neglected care of the patient, tracheostomy patient, is communication. Once you tracheostomy with patient, you put the patient continuously on positive pressure ventilation or TPs. You don't make the patient communicate very frequently. So we can make the tracheostomy patient speak while the patient is on ventilator and while the patient is off ventilator also. While the patient is on the ventilator, there are two ways we can make the patient speak. That is subglottic speech. The other is while using a speaking well. I'll discuss in detail about these two techniques. First, you need to understand some basics of communication while the patient is on tracheostomy tube. So to make the patient speak, air has to pass through the upper airway and the vocal cord. What happens while the patient is on tracheostomy is during positive pressure ventilation, air goes through the tracheostomy tube into the lower airway, and during exhalation, as the tracheostomy tube cuff is completely inflated, no gas goes through the upper airway. Air is bypassed through the tracheostomy tube and is exhaled through the tracheostomy tube into the ventilator. It is exhaled out actually. As no gas passes through the upper airway, the patient won't be able to speak when the tracheostomy tube is in place actually. So to make the patient speak while the patient is having tracheostomy tube, you have to do three different things. One, you have to deflate the cuff completely. So once you deflate the cuff completely, there will be some space between the tracheostomy tube and the tracheal wall. So through this space, the exhalation gas or during expiration, gas will go through the upper airway and the vocal cord. That will help the patient to speak. Or you can use a fenestrator tube. So during exhalation, gas can escape through the fenestration into the upper airway and the vocal cord so the patient can speak. The third important thing is how to close the tracheostomy tube opening either with the cap or plugs, or you can use a speaking elbow. You have to do three different things. You have to deflate the cuff, you can use a fenestrator tube, and you have to close the tracheal opening with tracheal caps, or you can close it with tracheal plugs actually. So what is speaking well? Speaking well is basically a unidirectional valve actually. So it allows the gas to pass through the tracheostomy during inspiration. However, during expiration, this valve will be completely closed so that no gas can pass through the tracheostomy tube during exhalation. So the air will be bypassed to the upper airway. That will help the patient speak. So that is called a speaking well actually. So to use speaking well, first do adequate proper oral suctioning. You do proper tracheal suctioning. Slowly deflate the cuff over 2 to 3 minutes. Then once you deflate the cuff, if the patient tolerates cuff deflation, then use your thumb to completely close the tracheostomy tube opening. So now you have deflated the cuff, occluded the tracheostomy tube opening. So ask the patient to speak. If the patient speak, then you apply the speaking well. So whenever you are using a speaking valve, monitor the patient closely for any respiratory distress, hypoxia, or desaturation. So deflate the cuff, close the tracheal opening with the speaking valve. You can use tracheostomy cap or you can use tracheostomy plugs also. So that way, air will be bypassed through the upper airway. That will help the patient communicate. Then contraindication. So don't apply speaking valve or tracheal cap when the cuff is completely inflated, because if the cuff is inflated, no gas can pass into the upper airway. Once you have applied the tracheostomy cap, no gas can escape through the tracheostomy tube also. So inspiration can happen, so exhalation cannot happen. The patient will die. So make sure when you are applying a tracheal cap or you are using a speaking valve, the tracheostomy cuff is completely deflated. When the patient is having copious secretion, the patient is having upper airway obstruction, don't apply speaking valve. Then, so far I have discussed how to make the patient speak while the patient is off ventilator. There are several techniques that can be used to make the patient speak while the patient is on ventilator also. That is called inline communication technique. There are two techniques that are commonly used. One is subglottic speech technique, or the other is inline passive valve actually. For subglottic speech technique, you need a specialized tracheostomy tube. The specialized tracheostomy tube is a tracheostomy tube with a subglottic suction port. I have discussed this tube in detail in the previous slide. So the subglottic suction tube with separate subglottic suction port is mainly used to prevent microaspiration of the oropharyngeal secretion. It prevent ventilator-associated pneumonia. So if the patient have a subglottic suction tube in place, so there are two main differences between the subglottic suction, subglottic speak and the inline passive valve. During the subglottic speak, the cuff has to be completely inflated. Actually, you don't deflate the cuff. To ensure positive pressure ventilation, you don't deflate the cuff. To enable the patient speak, we insufflate some amount of gas with the 100% oxygen through the subglottic suction port. Actually, insufflate 5 to 6 liters of 100% oxygen through the subglottic suction port. So as the cuff is inflated, you will be able to provide positive pressure ventilation. As you are insufflating gas through the subglottic suction port, as the cuff is inflated, the insufflated gas will escape through the upper airway. That will help the patient to speak actually. So the technique is, first, before insufflating the gas, make sure you have completely suctioned the oral secretion and tracheal secretion. Make sure the cuff is inflated. Don't deflate the cuff. If you deflate the cuff, you won't be able to provide positive pressure ventilation. Then slowly aspirate the subglottic suction port for any secretion, that is, remove all the oropharyngeal secretion through the subglottic suction port. Once you have completely suctioned out the secretion, attach the subglottic suction port through gas inflation of around 5 to 6 liters, give 100% oxygen. So by insufflating, as the cuff is inflated, the insufflated gas that is insufflated will escape into the upper airway, so the patient will be able to speak actually. Don't use this technique continuously. Use only for 10 to 15 minutes. If the patient is tolerating, every 2 hours you can use for 10 to 15 minutes. As you are insufflating the gas, there is some risk of subcutaneous emphysema. So monitor the patient very closely while you are using subglottic speech technique for communication. The other technique while the patient is on ventilator or positive pressure ventilation is inline passive valve technique. So that the valve is same, that is a single unidirectional valve that will allow inspiration, that will not allow expiration. So for inline, that is when the patient is on ventilator, there is a specialized passive valve. That is, this passive valve is called the PMV 02001. That is called the PMV Aqua actually. So this can be connected directly to the ventilator circuit. So the other tracheostomy tube, that is passive valve 2001, can also be used for patients while the patient is on positive pressure ventilation. However, you need a specialized adapter or tubing to connect the passive valve into the ventilator circuit. However, the passive valve 007, that is passive valve Aqua, if you are using this passive valve, that can be connected directly into the ventilator circuit. For other passive valve, you need a special connector or adapter. So whenever you are using inline communication technique or inline passive valve, so patient should not be requiring very high FiO2. The peak requirement should be less than 10. The peak inspirated pressure should not be more than 40 centimeter of water. So there is some key difference between subglottic speech and inline passive valve technique. For subglottic speech technique, the cuff is kept completely inflated, whereas for inline passive valve technique, the cuff is completely deflated actually. So in passive valve technique, so in subglottic speech, you need a specialized tracheostomy tube, that is tracheostomy tube with a subglottic suction port, whereas for inline passive technique, you need not require any specialized tube. The normal tracheostomy tube can be used actually. So what is the technique here is, first, for example, if since in passive technique, you need to completely deflate the cuff actually. So as you are deflating the cuff, to ensure positive pressure ventilation, you have to increase the tidal volume, or you have to increase the airway pressure, so that both communication can also happen. You will be able to provide positive pressure ventilation. First, before deflating the cuff, you measure the pre-cuff deflation positive peak inspiratory airway pressure actually. First, you measure the positive peak airway pressure. Then we measure the exhaled tidal volume. For example, if the tidal volume is if the exhaled tidal volume is around 400 ml, then you slowly deflate the cuff over 5 minutes actually. Once you deflate the cuff, since the patient is on positive pressure ventilation, some amount of gas will escape through the cuff, escapes over the deflated cuff. You measure after deflating the cuff, you now measure the exhaled tidal volume. You see the difference between the exhaled tidal volume before cuff deflation and after sufflation, which has to be around 40 to 50%. For example, before cuff deflation, if the tidal volume of was 500, after cuff deflation, it has to be around 200 to 250. What does it mean? It means that there is adequate space between the tracheostomy tube and the tracheal wall. So only if there is adequate space between the tracheostomy tube and the tracheal wall, the patient will be able to communicate. So if we are ensuring adequate leak, we are making sure that there is adequate space between the tracheostomy tube and the tracheal wall. As you are deflating the cuff, obviously there will be a leak, so there will be a drop in peak airway pressure. To ensure positive pressure ventilation, you have to increase the tidal volume, or you have to increase the airway pressure slowly to meet the pre-cuff deflation peak airway pressure. First, you deflate the cuff. Before deflating the cuff, make sure you suction the orotracheal secretion and the oral secretion and tracheal secretion. Slowly deflate the cuff. Before deflating the cuff, see the peak inspiratory pressure. After deflating the cuff, gas will escape both into the upper airway, and some gas will go into the lower airway also. Then, to ensure positive pressure ventilation, you gradually increase the airway pressure or increase the tidal volume to the pre-cuff deflation inspiratory pressure. So by increasing the tidal volume or the peak airway pressure, you are ensuring adequate oxygenation and also ventilation. By deflating the cuff, we are allowing the gas to escape into the upper airway so that the patient will be able to communicate actually. So this is the inline passive valve communication technique. So there is some subtle difference, as I said. For inline passive valve technique, cuff has to be kept deflated, whereas subglottic speech technique, cuff has to be completely inflated actually. You need a specialized tracheostomy tube for subglottic speech, whereas in passive technique, you can use a normal tracheostomy tube. Then what is decannulation? So decannulation is similar to extubation actually. So decannulation is the process of removing the tracheostomy tube once the need for the tracheostomy tube has resolved actually. So what is the benefit of decannulation? Why should we decannulate as the patient is already having a definitive airway? One, tracheostomy tube is a foreign body. Once you have a foreign body in the airway, it will increase the cough, it will increase bronchoria secretion actually. So it will impair swallowing actually. If your tracheostomy tube is in place, it will impair swallowing. So normally what happens during swallowing, there will be elevation of trachea. During elevation of trachea, larynx will abut with the epiglottis that will prevent aspiration actually. So normally there is a myth that tracheostomy tube will prevent aspiration is a myth actually. What happens normally when the tracheostomy tube is in place is, it will impair swallowing, it will impair tracheal elevation during swallowing. So it will increase the risk of aspiration. When the tracheostomy tube is in place, the patient will be able to communicate properly, patient will be able to cough properly. So by decannulating or by removing the tracheostomy tube, we can remove all these complications. So the coughing will go down significantly. The patient will be able to cough and clear the secretion effectively. Patient will be able to communicate. Swallowing will be better. There will be decreased risk of aspiration when the tracheostomy tube is removed actually. So what is the indication for decannulation? So mainly once the underlying reason for tracheostomy is resolved, we can safely decannulate the patient. Already from the beginning, I have clearly told the three main indications. One is upper airway obstruction. In upper airway obstruction, once the upper airway obstruction is completely resolved, for example, in retropharyngeal abscess, you have drained the abscess, do a fiber optic laryngoscopy. There is no upper airway obstruction, you can safely decannulate the patient. Whereas in other two indications, you have to closely monitor the patient before decannulating. In contraindication, when the patient is having upper airway obstruction, you cannot decannulate the patient. When the patient is hemodynamically unstable, you cannot decannulate the patient. Similar to weaning and extubation, there is some the decannulation is also a process that is a 6 steps process actually. First step is you have to assess the readiness for decannulation. The second step is assess the toleration of cuff deflation. And the third step is deflated cuff tracheostomy occlusion procedure. And the fourth step is functional decannulation. The fifth step is decannulation procedure itself. And the fifth step is once the decannulation procedure fails, then you can use alternative intervention for the failed decannulation. We'll see what steps one by one. First step is you have to see whether the patient is ready for decannulation. So there are some pre-fill criteria that has to be fulfilled before you are proceeding for decannulation. First, the patient has to be hemodynamically stable. The patient should be ventilator independent for more than 24 hours. The patient should have an intact sensorium. Patient should have adequate cough strength. The patient should be able to cough and clear the secretion. If the secretions are very thick and purulent, if you require very frequent suctioning, if the cough strength is poor, you cannot proceed for decannulation. Once all this criteria is fulfilled, then you go to the second step actually. The second step is cuff deflation. That is, assess whether the patient is tolerating cuff deflation. So as the patient is tracheostomy or tracheostomy dependent for past so many days, once you deflate the cuff, the patient will be exposed, the expirator gas will pass through the upper airway after so many days. The patient will react very strongly. So first you see whether the patient is tolerating the cuff deflation. So before cuff deflating the cuff, do proper oral suctioning, do proper tracheal suctioning, slowly deflate the cuff over 3 to 5 minutes. Some patients may react strongly to cuff deflation. Monitor the patient closely for any complications. If the patient tolerates cuff deflation, then you proceed to the next step. Next step is trial capping. So what is trial capping? Basically, once you have deflated the cuff, close the tracheostomy tube opening with your gloved finger for 1 minute actually. So now you have deflated the cuff. Now you have occluded the tracheostomy tube. So the gas will, during exhalation, the gas will escape into the upper airway. So you are allowing the patient to breathe through the nasal natural pathway. So once the patient tolerates 1 minute of tracheostomy tube opening with gloved finger for 1 minute, then you can proceed to the next step. While occluding the tracheostomy tube, closely monitor the patient for desaturation, respiratory distress, any signs of increased workup breathing, closely monitor the patient. The patient is showing all this sign, don't proceed to the next step. Then the fourth step is once you have confirmed the patient is tolerating cuff deflation, tolerating tube occlusion, then you go to the functional decannulation or functional capping technique actually. You can use tracheostomy plugs or tracheostomy caps. Sometimes you can use speaking well also. Don't use speaking only if you're planning for decannulation. You can use tracheostomy plugs or tracheostomy cap. So by using a tracheostomy cap, you have occluded the tracheostomy opening. You have completely deflated the cuff, so the air will pass, or during exhalation, air passes through the natural. So you are allowing the patient to breathe through the natural pathway. So you monitor the patient closely for 24 hours. If the patients doesn't show any signs of respiratory distress, no desaturation, you do no signs of respiratory distress, no signs of increased workup breathing, after 24 hours, you can safely remove the tracheostomy tube actually. Then what is capping failure criteria is if the patient is requiring more FiO2 or the patient shows signs of respiratory distress, if you had to remove the tracheostomy cap for any reason, for either for suctioning, desaturation, or respiratory distress, then that is considered as a capping failure technique. Then don't decannulate the patient. You assess the reason for capping failure, then you do all the process again actually. If you have patient have tolerated the capping technique for more than 24 hours, you can safely decannulate or remove the tracheostomy tube actually. So decannulation basically you first it's basically a 6-step procedure. First step is you remove the tracheostomy tube. Second step is, once you remove the tracheostomy tube, clean the stoma with the saline actually. Then apply tincture benzene around the stoma. Then you apply sterile strips over the tracheal stoma. Then keep a gauze piece or gauze roll over the stoma. Then apply primopore dressing. Then educate the patient or educate the family member to keep the finger over the stoma while talking and coughing actually. So first step, first step is the patient is hemodynamically stable. If the patient don't require mechanical ventilation for more than 24 hours, you can plan for decannulation. First step is you assess whether the patient is ready for decannulation. So patient should be hemodynamically stable, ventilator independent for more than 24 hours. Patient should be able to cough and clear the secretion. Patient should have a good GCS. Then once all this readiness criteria is fulfilled, then slowly deflate the cuff. If the patient tolerate the cuff deflation, then you do a trial capping by finger occlusion. If the patient tolerates finger occlusion, then you proceed with the functional capping. That is, close the tracheostomy tube with either a tracheostomy plugs or tracheostomy cap. Wait for 24 hours. If the patient didn't show any signs of respiratory distress, then you can carefully decannulate the patient safely. Or if the patient shows signs of respiratory distress or the patient requires higher FiO2, or if you have to frequently remove the tracheostomy tube cap for suctioning, then that is considered as a failed capping. Don't proceed with the exhalation. Then you first rule out whether if there is any upper airway obstruction. Do one fiber optic laryngoscopy. Look if there is any upper airway obstruction. If there is any upper airway obstruction, appropriately intervene. If there is no upper airway obstruction, then it indicates that there is no adequate space between the trachea and the tracheostomy tube. You can downsize the tube. That is, if you have tried the weaning or decannulation procedure by a 7-size tracheostomy tube, decreases, you will change the tube to 6 millimeter tracheostomy tube, again follow the same procedure. Then what is failed decannulation? So failed decannulation is after removal of the tracheostomy tube, if we had to reinsert the tracheostomy tube within 48 hours to 96 hours, it is considered as a tracheostomy decannulation failure. Normally 2 to 5% of tracheostomy failure, decannulation failure rate is completely acceptable. What to do with the decannulation failure rate procedure is, as mentioned before, do a fiber optic laryngoscopy, look for any upper airway obstruction. The upper airway obstruction is, if there is any upper airway obstruction, treat it appropriately. If the upper airway is completely normal, do a fiber optic bronchoscopy through the tracheostomy tube. You look for any tracheal stenosis or tracheal narrowing, you intervene it appropriately. So if there is anything, that is, if there is any obstruction, you do surgical intervention for the obstruction. If there is vocal cord palsy, try to do if it can be managed surgically. If there is any tracheomalacia, place a tracheal stent. If nothing is there, if the patient is, if you're not able to decannulate the patient mainly because of neuromuscular weakness or increase in secretion, then obviously you have to maintain the patient with long-term tracheostomy with the inner cannula. And then coming to the final part of the lecture, tracheostomy bleeding. I will not be discussing in detail because of lack of time. So tracheostomy bleeding is broadly classified into early bleeding and delayed bleeding. So early bleeding is basically any bleeding that happens within a week is considered as early bleeding. Any bleeding after a week is considered as a delayed bleeding. So early bleeding is mainly due to surgery-related complications. It can be due to minor arterial or venous bleed during the procedure itself, or it can be medication if the patient is on anticoagulation, if the patient is having coagulopathy, minor bleeding can happen during the procedure. Or sometimes during the tracheostomy or after the procedure, that can be minimal mucosal or because of minimal mucosal tracheal injury, minimal bleeding can happen. So early bleeding is usually manageable. Usually it will be minimal, managed safely. However, there is an important cause for delayed bleeding is erosion into the artery, that is tracheoinnominate artery. Though the incident is very rare, it is less than 1%. If we encounter such problem, it is basically, it will be fatal unless you do an emergency surgery. So what is tracheoinnominate fistula? Basically, what is tracheoinnominate artery is basically the cephalic artery, the first branch of the ascending aorta. So it will ascend up anterior to the trachea and it will divide into the subclavian artery and the common carotid artery just anterior to the trachea. If you have used a tracheostomy tube for a prolonged period of time, or if you have used a higher cuff inflation pressure, sometimes the tracheostomy tube or the tracheostomy tube tip can erode into the tracheal wall, into the brachiocephalic artery. can lead to torrential or catastrophic bleeding. So what is tracheostomy filter is basically erosion of brachiocephalic artery by the tracheostomy tube cuff or a tip that can lead to profuse life-threatening bleeding. The incidence is very low, less than 1%. However, it is generally fatal without an emergency surgical intervention. So any bleeding after 3 to 6, any bleeding between 3 to 6 weeks post-insertion should be considered as tracheostomy fistula until and otherwise proven otherwise. The peak incidence is between second week to third week actually. Majority of the patient, at least 50% of the patient before the major catastrophic bleeding will have some sentinel bleeding in the form of minor bleed actually. So any tracheal minimal bleeding in the second week or third week should not be neglected. Carefully look for any tracheostomy fistula. So what to do immediately if you are in the ICU, if the patient is having torrential bleeding from the tracheostomy tube, what should you do immediately is, the patient is having tracheostomy tube and the cuff is inflated, don't try to remove the tracheostomy tube, don't try to deflate the tracheostomy tube. If the tracheostomy tube in place and the cuff completely inflated, it will have significant tamponade effect on the wall that will decrease the bleeding. If the cuff is already completely inflated, you overinflate the cuff to up to 60 centimeters of water. By overinflating the cuff, it will increase the tamponade. It will try to compress the vessel between the manubrium sternum and the vessel. So by tamponating effect, the bleeding can be stopped. If you are not able to stop the bleeding either by overinflating the cuff, you remove the tracheostomy tube, intubate the patient with the endotracheal tube, you insert your finger through the tracheostomy stroma, then you compress the vessel between the manubrium sternum and the finger actually. So first overinflate the cuff. If you are not able to arrest the bleeding by overinflation of the cuff, remove the tracheostomy tube, intubate the patient, insert your finger through the stroma, you compress the vessel between the manubrium sternum and the finger. So you need to know this technique. We very rarely will encounter such complication. However, if you don't do it on time, you're going to lose the patient. So by doing, but this is only a temporary intervention. This will prevent bleeding only temporarily. How to shift the patient for emergency sternotomy and bleeding for bleeding control actually. So everyone should, for keep managing a tracheostomy patient should know this maneuver actually. So in conclusion, the timing of tracheostomy is very crucial. Early tracheostomy can reduce ventilator duration of mechanical ventilation, decrease ICU stay, and decrease the sedation needs. But you have to carefully select the patient. How to time, basically based on patient-to-patient basis. There is no fixed timing for every patient. So some patient may benefit from early tracheostomy, some patient you can wait up to 10 to 14 days actually. Choosing a right side tracheostomy tube is very important, and understanding its pros and cons ensures safety and effective care. Communication strategies must be incorporated to preserve patient's dignity and interaction. Decannulation should be well timed and systematic based on patient's readiness and safety. Be vigilant for any complications like tracheostomy fistula. Early detection can be life-saving. Thank you so much.
Thanks, Dr. Velmurugan. So please stop share screen. So, Dr. Velmurugan, very nicely taken, beautiful lecture. Just a few things, maybe you can also tell the audience what are the complications of tracheostomy, immediate and slightly delayed complications.
Are you able to see my face, sir? I'm not sure.
Yeah, I can see you. So the complications, immediate complications and delayed complications. So one you told was the TIF, right? The bleeding.
No, the immediate complication is mainly during the tracheostomy procedure itself. Patient can have bleeding manifestation. Either it could be because of bleeding, because of surgical intervention itself, because of injury to the vessel. It can be because of coagulopathy. So that can be managed by using cautery, or if the surgeon is around, it can be managed effectively. Now, another important major immediate complication is basically pneumothorax. That can happen during surgical tracheostomy, or it can happen during percutaneous tracheostomy also. So while doing tracheostomy, if the patient is having desaturation of the airway pressure goes up significantly, carefully see the patient for any subcutaneous emphysema so that you can intervene immediately to prevent any life-threatening complication. The third major complication that can happen during immediately that can happen during the procedure is insertion into the false fissure. Even if you do surgical tracheostomy, if you do percutaneous tracheostomy without bronchoscopic guidance, there is chance of false insertion of the tube into the false duct. Actually, make sure if you have adequate monitoring like ETCO2 to confirm the tracheal position, make sure you do the percutaneous tracheostomy under bronchoscopic guidance to avoid insertion of the tube into the false duct. The late complications, major complications, I said it's a tracheoinnominate fistula. It's a life-threatening complication. If you don't manage immediately, you are going to lose the patient. You should know the technique how to manage the bleeding immediately. The other complication that can happen during late procedure is subglottic stenosis. The main reason for subglottic stenosis is using a larger size tracheostomy tube. If you're inflating the tracheostomy tube cuff over a very high cuff pressure, if you're using a tracheostomy tube very high cuff pressure, that is more than 30-35 centimeter of water, the high cuff pressure will impair the tracheal mucosal flow. That will increase the risk of stenosis actually. Always select the appropriate size of the tracheostomy tube so that these long-term complications can be prevented. Mainly the granulation tissue, we don't use appropriate. If you're using a fenestrated tube, the fenestrated tube is associated with increased risk of granulation tissue. So make sure you don't use the fenestrated tube unnecessarily. Use the fenestrated tube only if you are planning for weaning or communication purpose. Use the fenestrated tube. Otherwise, use a normal or a non-fenestrated tracheostomy tube.
All right. And tracheomalacia can also occur if the tube is in place for some time.
Prolonged tracheomalacia can happen. Yeah.
Okay. Any questions from the audience, please? Okay, Dr. Velmurugan, really thank you. Beautiful lecture. And I think audience also loved it. Very educative. And soon after a couple of weeks, we'll put it up on the channel, YouTube channel for everybody to see. Thank you, Dr. Velmurugan. Bye-bye. Thank you, audience. Thank you very much.
Thank you, sir. Thank you.